So with this interesting panelists and experts, we will start our interactive case discussion. We will be having two cases this morning, inshallah. This is interactive, so please, we need to have you prepare your mobile phones, smartphones, and scan the barcode when you see it for the questions. If you have any questions, if you have any comments, if you have anything to add, we love and like you to come up and please go ahead and ask any question or basically give us your comments. So let's start with the first case. So this is a 24 Saudi male patient with unremarkable medical history. He presented with a chief complaint of recurrent cutaneous abscesses. His story started in 2018. Initially, he developed an abscess, a superficial abscess, at the left lower paradorsal region, so posteriorly. At that time, he was also coughing and having some fatigue and excessive sweating. Did not report any fever or chills, did not have any other systemic illnesses or complaints. At that time, he was living in southern Kentucky in the US. He was studying there for 3 years. This is a picture of some of the abscesses so that you can see. So this is an abscess after the IND, and this is more on a fresh abscess again with some virulent discharge. This is the same patient. In the US, he was seen in a surgical clinic, and they offered him incision and drainage, and they got him on some oral antibiotics. He improved initially, partially, but within 3 months the abscesses recurred. So he went again to the surgeon, and they did another IND with again oral antibiotics and partial improvement. In 2019, he traveled back to Saudi Arabia. After arrival, these abscesses recurred. This time, he decided to go to an internist rather than a surgical consultant. Again, seen in internal medicine, the same, he was offered IND and oral antibiotics. And I don't think they send it for culture anyways. They don't like the same cultures. So over the following months, the abscesses did not recur, but he had worsening respiratory symptoms with excessive sweating and more exertional dyspnea, and he's losing weight. So he lost more than 8 kilograms in that time. In October 2019, he was admitted to a hospital where he had some concerning findings. This is the first time this patient had any imaging studies done for him. So because of these imaging findings, they decided to transfer him to another facility. At the time of examination, he was thin, but he's well-oriented and he's not in distress. His oxygen saturation was normal on room air, afebrile, vital signs were mostly stable. He had decreased air entry at both lung bases, but the right side was with more decreased air entry. The findings were more pronounced over the right side. He had multiple scars at the site of INDs at his back, but the remainder of the physical examination is unremarkable. His white count was 8, his hemoglobin was 10.8, so he's anemic with low MCV, platelets 375, CRP elevated, more than 240, ESR more than 90, ALT a bit elevated, but the AST was normal, and the rest of chemistry was normal. They did serologies for him for Brucella, HIV, they were negative, and he had a PPD skin test, and this was negative. The chest X-ray showed the pleural effusion, and the CT scan, this is the CT scan, so if you look at the chest X-ray, so you can see there's blunting, there's over the right costophrenic angle, and there's lots of volume here. If you look at the CT scan, you can see there's some reaction in the lung. You have here pleural effusion with thick pleura, and look at the paradorsal region. You can see basically paraspinal collections. Now, if you look at the MRI, he had an MRI, and again, you can see the current final collections, not at one level, at multiple levels, as you can see here in this MRI. Okay. So given the patient's clinical presentation and imaging findings, what is the best infection control advice when you admit this patient? So this patient is being admitted, so what to do with this patient? A, place in an airborne infection isolation room until you get 3 negative sputum smears for AFB. B, place in a private room under contact isolation. Well, you have the rest. Vote, please. Okay, so the question here, if you have a patient with this presentation, would you be worried about TB or not? Dr. Khalid, what do you think?
Right. Yeah, I think this definitely can go with TB. The cutaneous lesions, abscesses, not typical TB. Usually have deeper abscesses, but it can be TB. Definitely the pleural effusion or empyema with the infiltrates also can go with TB. So yes, absolutely, I would be for that. In terms of the studies, you mentioned HIV and some serologies. One disease I like to rule out, although he's 24, but we have seen CGD later. So CGD I'd like to definitely rule out as a defective defense mechanism.
I would agree. For this patient, I would put TB on the top of the differential diagnosis, giving the longevity of the and the recurrence and the weight loss and the fever and the chest finding that I don't have an explanation at this time. Protecting my colleagues and working in the institution and also the other patient, I would rather put him in a negative pressure room for the next 24, 48 hours until I get reassured that AFP is negative. Although his BBD is being done and it's negative, which doesn't help in this case scenario, because even if this disseminated TB, BBD would be negative because he has no cellular immunity enough to do that. So I wouldn't do a BBD for him.
Dr. Ali, can we link the cutaneous abscesses to this, basically these collections, paradoxal collections, and the pleural fluid?
I think yes. One of them is, we have seen TB cutaneous and abscesses internally, but also other organisms, staphoids, to do the same thing, and cutaneous lesions and also liver sites. I would think also of some other with CGD disease. If he had, if I have history of having recurrent infections while he was young, although it could happen in teenagers. I wonder during his stay in Kansas if he had picked up anything there from the environment or from الانهار والبحيرات الموجوده هناك. At the same time, I would insist على getting the culture, getting the specimen to do cultures, PCR, and others. I mean, I would take it step by step, but for the time being, put him in a protected environment.
One thing I think has to be also thought of is nocardia. I mean, lung cutaneous nocardia is, we see here TB and nocardia well in the other diseases. If we look at infections, it's about exposure and defense. And he's been living also in areas where can have exposure to other organisms. So I think always travel history or where the patient has been living is very important.
Okay, thank you. So the patient basically did not have at that time, ID was not involved, so the patient did not have any of these done. So basically they basically went he underwent ultrasound guided paracentesis, and basically they got around 900 ml of purulent fluid. And if you look at the investigation, the pH was very low. The pH was 7, so this tells you this is really infected fluid. Protein was 100, LDH was very high, more than 1400. The white count was more than 26,000, so again, mostly neutrophilic. The cytology was same, and there was no malignant cells. Gram stain showed no bacteria. Bacterial and fungal cultures remained negative. Pleural fluid AFB smear and TB PCR from the fluid were negative. And TB cultures at that time were pending. So we have to wait for a few weeks to get the TB culture results. So during this time, what would you do? Given the lack of definitive diagnosis, what would be the next best action to be taken for this patient? A, get more samples for diagnosis. B, get a trial of anti-TB therapy. C, treat as a pyogenic infection. D, ask for ID consultation. E, observe. These vote. Well, PCR was done and it was negative. Well, at the time, they did not do sputum cultures and they did not for sputum AFB. They just went for the fluid. Okay. So if you're not IB, I think the answer would be perfect. But if you are an IB, Dr. Ali, what do you think?
I would get more sample for diagnosis, tissue sample. I wouldn't put him on anti-TB at this time. I think he worked some more investigation that could be done over the next couple of days or more. Myogenic infection with a prolonged course of antibiotic, he had tried twice or 3 times before, so I don't think it would be the same. Except if he had, a blood like safe, they are prone to get recurrent myogenic infections. So I would go with more sample for diagnosis, tissue culture, cytology, also for the rest of the diagnosis for these lesions.
Yeah, I think he probably has empyema, and I think I would do pleural biopsy because it's closer to the pathology, and the yield will be much better, especially from histopath. So yeah, I would probably avoid anti-TB. Yet the PCR is negative. Yeah, and the fluid AFB may not be. It's unlikely to be positive even in TB, but the PCR is more likely to be positive. And again, if I had him in Kentucky, my differential diagnosis would be different.
So anyone would start anti-TB therapy from the or ID colleague? No anti-TB. Okay. So the treating team at that time, remember, they were not involved. They decided basically, since they don't have the clinical findings, suggestive of anything else, and the diagnosis, they still thought TB is more likely. And cultures will take 6 to 8 weeks, so they decided basically to treat the patient with anti-TB therapy. And the patient basically was started on the therapy, discharged to follow with his referring hospital. But in a month, he was admitted with liver toxicities related to his anti-TB therapy. So starting anti-TB is not really an easy decision. It's not without consequences. So when we start anti-TB, we should think ahead of time if the patient is really, number one, is it needed? And number two, if this patient has toxicities, what to do with this patient? So anyways, he was readmitted, and they dealt with his liver toxicities. They continued anti-TB therapy for 2 months. Then the cultures came back negative. Okay. So he continued with his waxing and waning symptoms, basically the same. he had repeated drainage of the pleural fluid in the referring hospital, and again, they sent it for cytology and cultures, but everything was negative. He was offered long courses of antibiotics to treat pyogenic infections, but again, no improvement tolerated. Fungal cultures were sent and they were negative. And actually 2 times. So the first time when they did the pleural drainage, and the second time when they did the pleural drainage. So now, what additional diagnostic tests should be done to establish the diagnosis at this time? A, PET-CT scan. B, repeated drainage and get tissue samples for pathology and microbiology testing. C, repeat therapeutic drainage and keep a drain in place. D, request ID consultation. E, observe. Well, this is good. So asking for ID consultation is always good if you are not an ID. Okay. Dr. Hyde, what do you think?
Yeah, as I have said before, yeah, we need better samples, especially tissue. So I think most of the responders, in my view, got it right. So even if you consult ID, he will recommend or she will recommend the going for tissue more.
A question: how sensitive would be the TB culture in a pleural fluid, or TB PCR, or TB AFP smear in a pleural fluid versus tissue?
Yes, it's really wide. I mean, from about 4 or 5%, from about 70%. So it's really it's important to get a tissue from the pleural when you have looks like empyema or inflammatory effusion.
So if we take tissue this time, what should it be sent for? So make sure we also remember to send for histopathology, because sometimes we get the diagnosis only in histopathology, not in cultures. Cultures are never perfect. So the patient was readmitted in 2020 again due to reaccumulation of pleural effusions, persistence of the paravertebral collections, and distal was abscess. ID were involved at this time. CT-guided drainage was attempted along with a core tissue. Now remember, fine needle aspirates are not good samples for diagnosis. So try to take a core. If we're getting like a CT-guided biopsy, it should be a core biopsy. So we get enough tissue sample for histopathology and for culture. That would be more representative sample. The other way to do it is by like VATS or some mini-surgical intervention. All culture results were negative from the fluid and tissue. So even with the tissue, we did not get anything from pathology, but the histopathology gave us this clue. So the first thing that you can see here, we can see multiple non-caseating granulomas, as this one here. If you can see the pointer, I don't think I must use this pointer. So you can see there are multiple areas. There are multiple areas of non-caseating granulomas. As you can see here, we have multiple granulomas. One is so multiple non-caseating granulomas are seen, and the pathologist was also, they did a silver stain, and they got these unusual forms, mostly in these granulomas. So this is a silver stain, and this is an H&E stain. So we have the granulomas, and we have these structures in the pathology. So what is this histopathologic finding? A, granulomatous inflammation with positive ZN stain. B, granulomatous inflammation with broad-based budding yeast. C, granulomatous inflammation with filamentous bacteria. B, only granulomatous inflammation. E, I don't know. Wow. So, what do you think? So let me go back on slide.
Yeah, I mean, you can see kind of a large budding yeast and with a broad base, as you see. And this is quite pathognomonic or characteristic of an organism. I don't know if you want me to disclose it or
No,
maybe
I
later.
think we have another question for this. Okay. So next question, which is the answer was correct. So which of the following fungi has the characteristic broad-based budding yeast? I just want to say this is the true pathology of this patient. This is his pathology, okay? And I'm not sure if the pathologist with us here, he is not. So having a good pathologist is also a good thing, always a good thing. So which of these basically fungi cause broad budding yeast? Okay. So Dr. Ali.
I think they got it right. It's a blasto. And it's well known in that area of cancer, that east side of the state, extend up to the northern territory and going into Canada. We have seen a few cases that has similar in our colleagues' physician who had blastomycosis, who were living in those areas. So it is compatible with the skin lesion, pulmonary. The thing that I didn't understand is the cast that we had from time to time, the response to the antibiotic. Could it be for the secondary infection or because of the blastomycosis?
Any questions?
Then we sent for pleural biopsy and TB cultures. They came with necrotizing granuloma. I'm not sure if it's necrotizing or gazeating. And unfortunately, it wasn't sent for TB cultures. We gave them empirically as a TB. Patient is not improving. On and off fever, weight loss still. He came with recurrent infections. Then we sent him for in the specialist hospital. We found that he had blastomycosis.
So
Can I-
these, yes.
Yeah. You know, blastomyces is called what? Blastomyces dermatitis. So dermatologic manifestation with blasto is a main actually. Then the lung, and depends. You may see more in the lung. In HIV patient, we have seen more in the lung and also disseminated. I was in Texas, so we had few cases coming always from the East Texas and Louisiana. So that's where you get through the Mississippi River Valley and up to Manitoba in Canada. And I think the case international has been published on a patient who had blasto and interesting enough, Dr. Ashraf Ali, I don't know, Dr. Ashraf Ali, he was the head of pathology at King Faisal in the 80s. And actually, he published in the American Journal of Tropical Medicine and Hygiene 2 cases, one from Medina and one from Taif, I think it's Saudi and Sudanese, if I remember right. And it was indigenous, sounds to be. It was not culture, it was just typical pathology. I think was in the lung, both cases. So it looks like maybe we have some blasto. Definitely it's not very prevalent, otherwise we would be able to diagnose some. But again, at least these two cases were diagnosed on histopathology and they were indigenous within the country.
This is more likely to be important. This is, yeah. Okay. So the final diagnosis, this is multifocal. So we have multiple organ involvement. So this is multifocal blastomycosis. And what is your treatment of choice for this form of blastomycosis? A, itraconazole. B, liposomal amphoB. C, voriconazole. D is avioconazole. E, caspofungin. Okay. So, Dr. Hyde, you want to comment?
It's maybe a tough call here. If you have a life-threatening or really bad blastomycosis, then you go for ampho. So on one hand, in this patient, you have it in multiple areas, so it is disseminated. On the other side, he is stable. So you can argue for either. If you are impressed with the radiology and what you have, probably you'll go with ampho, liposomal ampho. If you are more impressed with how good the patient look, which seems to be kind of a stable patient right now, I think, then itraconazole would be the choice. Definitely itraconazole, when it was introduced, it was really, a game changer in the treatment of blastomycosis.
So, Pete, your patients, would you offer him, at least offer him liposomal amphoB or just go straight with itraconazole?
If he is inpatient, I would probably try, days on ampho, at least tolerating them, no side effect. I think I'll feel probably kind of more relaxed about that. But if you decide on itra, I would not mind as well.
Okay. So this patient was offered liposomal amphoB given his basically disseminated infection, but he did not want to stay any day in the hospital, and he wanted just to be discharged, so he was given itraconazole 200 twice daily, and with a close follow-up. So in the coming 2 to 3 weeks, he started to improve, gaining weight with the resolution of most of his symptoms, especially the respiratory symptoms and the excessive sweating. He started to feel back, he is back to normal. And he tolerated well the itraconazole, and during the coming months, he had no additional drainage intervention. And in 4 months, we did these imaging studies for follow-up, and you can see basically the paraspinal collections and the pleural effusions has resolved. We offered him, because of the involvement of this extensive involvement, we thought we would treat him for longer course, so at least 6 months, but we offered this patient 12 months of therapy with itraconazole, and he did very well, and he was compliant with his therapy. So if anyone has any questions, any comments, yes, please. Well, if you have the solution, I would go with solution, but we had access to the itraconazole tablets, so we offered him tablets. But Dr. Hyde, what do you think?
Yeah, of course, solution for absorption would be better, but what we've noticed, diarrhea is quite common in those patients. I remember we were giving it to mice in one of the studies, and even mice, they had diarrhea with itraconazole, so liquid. So no, I think capsules would be good. If you can do levels monitoring, then that would be perfect. It has to be with food, acid to get absorbed, because it comes in a capsule and has granules. I don't know if you opened it. I did open it. It's like sand, actually. So it's very tough, and you need to kind of grind it, have some acids to get it absorbed. Yeah, bone absolutely can be involved. Yes.
And I think in this patient, you have to assume bone has been involved, so this is why we have to treat for like 12 months of therapy. I think we don't have much time for more questions. Let me just go to the second case. Yes, it's about last. So this is our second case. This is a 79-year-old male patient, Saudi from Tabuk. His past medical history is positive for type 2 diabetes, hypertension, dyslipidemia, coronary artery disease, AFib, BPH, and TAVI in 2022, CABG in 2019. Also cholecystectomy in 22. He is a heavy smoker. He presented with a 3-month history of exertional shortness of breath, fatigue, sleepiness, decreased appetite, and weight loss of 10 kilograms. He's feeling very fatigued. Did not have fever or chills or sweats or chest pain, but he had right upper quadrant abdominal pain that almost started at the same time. During his current illness, he was admitted twice to hospitals. The first time they did some workup that included CT scans, but again, they did not find anything. The second admission, they decided to go for upper and lower endoscopy because of the right upper quadrant abdominal pain. And they told him he had some gastritis and offered PPI, but his symptoms persisted, so he was discharged. So on initial presentation, he was afebrile, not in distress. Oxygen saturation was normal at room air, had good air entry bilateral, but some decreased air entry at lung bases a bit. Distant heart sounds, but he did not have any murmurs. Abdominal examination was just positive, right upper quadrant, mild tenderness, no guarding, no rigidity, no other signs of acute abdomen, no edema. His white count was 13, hemoglobin 13, white count 7.8, 75% pigmented, platelets were a bit low, 139. LDH was 162, liver enzymes otherwise, and the chemistry were unremarkable as well as urine analysis. So this is a patient with a 3-month history of fatigue, exertional shortness of breath, and weight loss. Given the patient's history and the clinical presentation, what investigation should be done next? Shall we do anything for him or just observe? A, echo to assess for infected endocarditis. This patient has TAVI. B, chest CT scan to assess for pneumonia, TB. C, CT abdomen and pelvis. D, blood cultures to assess for bacteremia, endocarditis. E, all of the above. F, none of the above. So no one voted for none of the above. Dr. Ali, what do you think?
When we had such case, we usually start with the non-invasive, cost-effective approach. First of all, we took a good history, we do a good physical examination, and we start with the basic things that the lab. That would probably direct us to certain pathway of diagnostic pathway. Doing all of this, and then finding that he has a blood culture, let's say that had 6 out of 6 an organism, that would make the CT scan abdomen pelvis, CT scan of the chest is a waste. So if he had some pathology in his abdomen, I will do a blood culture for him. I listen very good to his heart, very, very murmur, but with the new MDs, I might do an echocardiogram. Since he has an abdominal, the next step, the next day or the day after, I would probably go ahead and do the CT scan of the abdomen to see if there is any pathology there.
Having a TAVI would make the differential diagnosis different.
Yes, it would, given that he had previously cardiac interventions, especially it's 22, and it's within the last 2 years.
Dr. Khalid.
I'm impressed with the 3 months history. I mean, this is really long, so he must have some indolent organism causing this. His later findings apparently in the chest. Right?
Not really that significant. Yeah, I mean, nothing much in the history and physical examination. The things in the history, the length of the duration of symptoms, and the weight loss.
If you are an administrator and the bed utilization is important and you want to do things fast because you can maybe save money, depends. You do all of these quickly and you finish quickly. Otherwise, which is more scientific sound, is to go stepwise. So I think medicine has moved from a stepwise to more of do it quickly, breathe a bit quickly. So,
Okay, so the patient had basic workup, blood cultures were sent to sets, echocardiogram was done, and it was unremarkable. He also had a TEE that was unremarkable, no vegetations, no fusions, nothing. And the CT scan of the chest and abdomen showed this basically. So I'm not sure if you can see the findings. So if you look carefully here, this is the heart, this is the body, and we have some kind of connection here. And this is enhanced, so the pericardium is thick and enhanced. This is the pericardium. And if you look here, you can see it as well, and there, so it's present in multiple locations.
so pericardial empyema sound.
And you have the tabby here. So this is the tabby. If you go down, this is the collection, this is the collection, this is the collection. And just to give you, this is basically, it's inferior, posterior to the heart. So the location is very unusual. And they could not see it in the echo. And even after the CT scan, they did another echo because they thought we should see it. They could not see it even after they knew this is the finding of the CT scan. So this is it again. So this is basically the collection. So the location is inside the pericardium, but inferior, posterior to the heart. Okay. Well, even again, after they knew the CT scan is showing these, they went back and they did another echo. They could not see it. Even they knew it's present, but they could not see it. Yeah, I'm not a cardiologist, but that's what we were told.
So is it within the pericardium?
It's within the pericardium, inside the pericardium.
Very strange. I mean, they did a TE as well. I'm surprised they couldn't see.
Well, they couldn't. Even after the fact, they went again. They checked the echo. They could not see it. They couldn't.
Because the TE, it's posterior. It's right there, touching the left atrium. So I'm very surprised. I'd like to review the images because, you know, I can maybe forgive them of the transthoracic, but the transesophageal, that's right there. So
I don't know.
unless it's loculated or maybe external.
It is located, and it's inferior almost. If you go back here,
Sure.
just if you look at the one below.
Yeah, yeah.
And it's inferior to the heart. This is very unusual. Honestly, I have never seen something like this. This is very unusual.
I think the combination of the previous cabbage as well, you know, they've stripped the pericardium, you can get adhesions and distorted anatomy, so, you know, that could be the most likely explanation for this.
So again, this is the CT scan, and the blood cultures after 3 days of incubation, they did not grow anything. So given the CT findings, what is the next best action plan? A, start broad spectrum IV antibiotics targeting both gram-negative and gram-positive bacteria. B, repeat blood cultures and start broad spectrum IV antibiotics. C, hold antibiotics until getting final blood culture results. D, proceed with drainage and send tissue and fluid for culture. E, repeat echocardiogram. Two sets initially sent. Then after this, 2 more blood culture sets were sent. Okay, so we have now 4 blood culture sets before starting antibiotics. Dr. Ali, what do you think?
I would agree to proceed with where is the bacteria, where is the money? Money is in the collection, need to be diagnosed quickly and
Is it enough to start broad spectrum antibiotics to treat this infection, or you need to have a drainage in addition?
no, I need to take the sample then start in empiric.
Is it only diagnostic or therapeutic?
Therapeutic, if it would be, there is a hemodynamic instability or otherwise, I would take as much as possible. also consider that he might need to go for a surgeon to strip that area.
But what if you can place a drain? Yani, would you place a drain to drain it, or just tell them I just need a quick sample? So sampling, yani diagnostic or diagnostic and therapeutic at the same time. Great. Dr. Khalid.
To me, it sounds like in pain. You can see fibrinous tissue, so absolutely drain, yes. So diagnostic and therapeutic.
So basically, that's what has been done. So the drainage was done, and a drain was left in place, and both fluid and tissue were got for histopathology and cultures. So both of them. So gram stain of the fluid, 2 plus gram negatives, and gram stain of the tissue, 1 plus gram negative. And both cultures, after 24 hours only of incubation, we got this shape of gram negative. So as you can see, lactose non-fermenting gram-negative bacteria after 24 hours. So this is early. So given the microbiology result, all of the following can be expected to be the causative pathogen except, so this is the exception now, Pseudomonas, B. Salmonella, C. Klebsiella, D. Burkholderia, and E. Acinetobacter. Okay, Mr. Khaim, what do you think?
Yeah, I mean, the rest are non-lactose fermenters. If you do oxidase, then you limit it to E and B. So just doing oxidase, then you eliminate also a few others, like the Burkholderia and Pseudomonas. Then you end up with Acinetobacter and Salmonella.
Okay. So blood cultures were repeated again, and the patient was started initially empirically before we got the final culture result on piperacillin, tazobactam plus cyclophosphamide. In the culture results, the final culture was reported to grow Salmonella enteritidis, susceptible to ceftriaxone, ceftriaxone, and cyclophosphamide. So the patient was given switched to ceftriaxone IV, and other antibiotics were stopped. And one blood culture after we had all of these interventions done, so 10 days after incubation, grew Salmonella, the first blood culture that was taken. So if we waited long enough, we could have got the result. But the rest of the cultures were negative after 2 weeks of incubation. So how long would you treat this patient with antibiotics? A, 2 weeks, B, 4 weeks, C, 6 weeks, D, 6 weeks of IV followed by a long course of antibiotics. E, I don't know. I'm not sure if anyone knows. Okay. Dr. Hai, what do you think?
First, I think Salmonella is becoming the great mimicker. I mean, we've been seeing more, I'm sure you're seeing more and more weird presentation of Salmonella, different organs. This is very indolent. You're talking about 3 months and then empyema within the pericardium. This is really serious, and yet the patient is not very, very sick. That's interesting. It's intracellular organism, and always with intracellular organism, we'd like really to go beyond because it's really difficult to eradicate when it's in deep tissue. So I agree with the responders, most of the responders on prolonged 6 weeks therapy.
And given he has TAVI, will we stop at 6 weeks, or should we offer him more suppressive course?
I think without evidence of vegetations, I would not, assume a difficult endocarditis or endocarditis within the prosthesis. I think still 6 weeks would be, to me, would be adequate, but I think he would need monitoring.
We have a cardiologist. What do you think? What is the sensitivity of the echo TEE for TAVI, not for the regular prosthetic valves. Honestly, I'm not quite sure about the sensitivity in TAVI. TAVI is a bit different. So what do you think?
I think it wouldn't be too different from the standard, but I think in this case, you might need to go for something more sensitive, such as a PET scan, just to see does it light up and does it show? I mean, with devices and things, if we don't see an infection, but we're still concerned because of the chance of a forming of a biofilm, a PET scan would be reasonable, I think, just to make sure that it doesn't light up. But I think that would be more sensitive than just using your standard TE. TE, if it shows, it won't show you if there's a biofilm that's formed on it. If you pick it up early before the endocarditis shows up.
But the sensitivity TAVI would be the same as like any prosthetic valve, or it's
It's similar.
different?
They're with the most recent valves, they're coated with both steroid and antibiotics, so they're quite protective, and I would say not as susceptible to infections such as the older generation valve.
Dr. Ali, any comment?
Mustafa, can you go back to the slide? When we started, there was a tagocine plus a civil. Was there any justification to add the civil? If we use a good dose of tagocine, that we could give it a Q6 hour full dose, why would we need a civil?
Well, we don't need to combine, but this at that time we did not know the pathogen, so we were not sure what we were dealing with. So is it Pseudomonas, gram-negative, that is lactose non-fermenting, and you have to think of certain pathogens, among them Pseudomonas. And we have a lot of resistance for Pseudomonas, honestly, and I was worried about Pseudomonas initially. But if you know the pathogen, definitely I wouldn't give combination therapies if I knew the pathogen at the time and the susceptibility. But empirically, I'm not sure. The reason for the combination is we did not have data on the pathogen nor the susceptibility.
Usually we go with the beta-lactam slides rather than having two molecules that there are no much synergistic on. Especially if we want to go into a more broader and more coverage to the pathogens. I agree with you that you need to be wider, but at the same time making sure that we're using appropriate civil in this case is going to be used for longer duration, so it would be safer for the inaccuracy.
The only problem with the aminoglycosides, they don't work well on abscesses. They don't, we have a lot of issues with aminoglycosides. And currently, if you look at the most recent series I, they have almost withdrawn amikacin, even amikacin, from most of the clinical infections except for UTI. So we don't have good activity for aminoglycosides on most of these pyrogenic infections, especially when you have collections or abscesses. If you're giving this for synergistic activity, that's I think this is a good idea. But I think at that time, we were thinking of just getting right the pathogen before we get the culture.
Did he have ultrasound for his gallbladder?
It was removed. He had cholecystectomy a couple of years earlier.
What was the method of detection?
It was done by Vitek, and serogrouping was done as usual with serogrouping. And this was detected, honestly, one of the blood cultures was done in a different lab, and the tissue was done in a different lab. So both of them came with the same diagnosis for Salmonella without knowing the results from each other. So this was tested in two different labs. Any questions? Sorry, and we have to finish. So the patient was offered, just quickly, the patient was discharged on ceftriaxone, treated for 6 weeks, and then switched to oral ciprofloxacin for he continued for 3 months, and he stopped at 3 months after that. And the follow-up after 3 weeks, he was doing very well. He had repeated blood cultures at 6 weeks as well, and all of them remained negative. We have to stop. Thank you, Dr. Kyle. Thank you, Dr. Ali.